I'm going to be speaking about hemolytic anemia. Hold on, let me make sure that I can. Oh, those are, well, there was a brief preview of my disclosures and the objectives for today's talk. I'm going to start with a few ways to classify hemolysis. We're going to talk about the laboratory findings in hemolytic anemias. Then I'll briefly touch on the most common hereditary red cell membrane defect, which is hereditary spherocytosis. We'll touch upon the most common red cell enzyme defect, which is G6PD deficiency. Then we'll discuss a little bit about autoimmune hemolytic anemia, both warm and cold, and then we'll talk about paroxysmal nocturnal hemoglobinuria. And if there's still time, which I don't think there will be, we'll be talking about, I can talk a little bit about thalassemias. So by definition, hemolysis refers to shortened red cell survival. And there are a couple of different ways of classifying hemolysis. The simplest ways of classifying hemolysis is whether it has something to do with the red cell or it has nothing to do with the red cell itself. So among the problems that we have with the red cells, we have the problem with the red cell membrane, and that category includes hereditary spherocytosis, which is the most common membrane defect, hereditary elliptocytosis, and paroxysmal nocturnal hemoglobinuria. And I should have mentioned earlier that in general, the problems that have to do with the red cell itself are usually the congenital problems. And the one exception to this rule is actually paroxysmal nocturnal hemoglobinuria, which is an acquired problem. So moving right along, if we have hemoglobin defects as corpuscular or red cell defect that can cause to increase hemolysis. And that includes things like sickle cell anemia or thalassemias. And then finally, the red cell enzyme defects such as G6PD deficiency, pyruvate kinase deficiency, and pyrimidine 5' nucleotidase deficiency are the congenital enzyme defects that can cause hemolytic anemia. Then the extracorpuscular defects leading to hemolytic anemia generally deal with external insult to the red cells. And again, in the majority of cases, they are acquired. And they can be classified in immune and non-immune mechanisms. That's really the main classification. From the immunologic mechanisms, we have autoimmune hemolytic anemia, which is where the antibodies are directed against self-antigens. We have autoimmune hemolytic anemia, for example, delayed hemolytic transfusion reaction. This is the case where the antibodies are directed against somebody else. The antibodies are foreign to the red cell antigens. Or we have drug-induced hemolytic anemia. And there's a couple of different mechanisms of hemolysis, which we'll probably touch upon a little bit later. There are mechanical defects that can cause hemolytic anemia, and most commonly, those include microangiopathic hemolysis from something like a mechanical heart valve or splenomegaly, or microangiopathic hemolysis. And here we're talking about thrombotic microangiopathies such as TTP, complement-mediated HUS, and DIC. And a less common category of hemolytic anemia is toxic or infectious, and that includes your infections such as malaria and babesia, and in addition, thermal burns and copper excess and lead poisoning. And spider and snake bites can cause hemolytic anemia as well. So this is kind of an overview of the hemolysis. Another way of classifying hemolysis is intravascular hemolysis versus extravascular hemolysis. And what extravascular hemolysis means is that the red cell is destroyed not directly in the vasculature. So in general, a good example of that is autoimmune hemolytic anemia, where you have an antibody-coated red cell, or the red cell that has an irregular shape for whatever reasons, for example, hereditary spherocytosis. So that cell is recognized as abnormal by the reticuloendothelial system, and it gets absorbed by the phagocytized by the reticuloendothelial system, degraded in the lysosomes. Then the hemoglobin gets processed and eventually converted to biliverdin and excreted through the liver and eventually in the stool. In this case, you have really minimal amount of extracellular hemoglobin. All the hemoglobin is contained and it's inside the cell. It's usually not a very severe process. We'll talk about a little bit about the clinical features of that on the next slide. The intravascular hemolysis is a much more serious process. This occurs when the red cell pops directly in a circulation, and it releases intravascular free hemoglobin, which is highly toxic to the system, and is the ability to control or to damage control the free hemoglobin is very limited, and the haptoglobin that we have is very sensitive to intravascular hemoglobin, and it takes about 50 cc's of blood hemolyzed to overwhelm that capacity of haptoglobin to bind the free hemoglobin. And if that happens, then the hemoglobin starts being excreted through the renal tubular system, which can cause renal damage. And you see what we call hemoglobinuria, which is basically the red urine. So what are the consequences of that? So the intravascular hemolysis is generally very acute in onset. It's usually severe, and the anemia is quite symptomatic. You can have fever, chills, and back pain, hypotension, and even shock. The good examples of intravascular hemolysis include acute hemolytic transfusion reaction, include severe burns, include PNH, microangiopathic hemolytic anemia, so any of the thrombotic microangiopathies, but also physical trauma, bacterial infections such as Clostridium, sepsis, and parasitic infections, as I've mentioned before, the malaria and Babesia. In the extravascular hemolysis, your body usually had a chance to adapt to the changes of the hemolysis, and it's usually not as much of a dramatic presentation. You have mild to moderate anemia, you have splenomegaly, because there is a, I guess, work hypertrophy of the spleen. These people generally have a history of gallstones. The urine is not red, it's more dark or tea-colored. The MCV could be variable, and the etiology of extravascular hemolysis, well, it's pretty much everything else. Most of the hemolysis that we see is extravascular. But in every pathophysiologic process of the anemia, there's this overlap between intravascular and extravascular hemolysis. So you can never say that something is purely intravascular or purely extravascular. There is a lot of overlap. In terms of laboratory values, the findings that we see in hemolytic anemia, you see reticulocytosis, assuming intact bone marrow response. You see unconjugated hyperbilirubinemia in both intravascular and extravascular hemolysis as a means of processing the hemoglobin that's released. The LDH is notably much higher in the intravascular hemolysis because the red cells contain a large amount of LDH, which gets spilled into circulation when the red cell pops. So with the intravascular hemolysis, you see much larger increases in the LDH compared to the extravascular hemolysis. The haptoglobin is always decreased in the intravascular hemolysis, as I've mentioned. It's very sensitive to even a small amount of blood hemolyzed, and it's generally decreased in extravascular hemolysis as well, but occasionally it can be normal, and that's very important to know that sometimes when you have a low-grade extravascular hemolysis, you may not pick it up with a haptoglobin. What you can, similarly, the plasma-free hemoglobin, you generally would see in a significant intravascular hemolysis as well as extravascular hemolysis, but it may not be detectable in pure extravascular hemolysis. Urine hemosiderin is a very interesting one. So let's say you had a patient that you suspected had an episode of extravascular hemolysis, intravascular hemolysis. A good example of that would be a patient that had a possibly hemolytic episode from G6PD deficiency. And you didn't get the haptoglobin at that time. You basically missed the boat on that, forgot about getting it. And you see the patient, or the patient presented to emergency room and they didn't get the haptoglobin. But you still want to know if the acute presentation and a drop of hemoglobin that was seen at the time of presentation to emergency room was because of the hemolysis. And you're seeing the patient 2 weeks later. Well, what you can do is you can order urine hemosiderin, because what happens in the intravascular hemolysis, the free hemoglobin, once it overwhelms the absorptive capacity, the neutralizing capacity of the haptoglobin, it gets excreted through the kidneys. And what it does, it binds to the proximal tubules. And when it binds to proximal tubules, it kind of stays there until the proximal tubule cells slough off, which usually takes a couple of weeks, 10 to 14 days. So if you think that the patient may have had hemolysis in the past couple of weeks, but you didn't catch them in time for whatever reason to check their haptoglobin, LDH, or the tests that you've done are normal, but you're still suspicious, this is a good test to send, and it's actually available in Monty. You can just order it as a urine hemosiderin. They end up sending it to Quest. So, and that test is usually positive if there is a component of intravascular hemolysis. Similarly, urine hemoglobin, which is something that you can see on UA when you have a positive red cells, but a positive blood, but no red cells, is something that you can find in the urine in an acute setting. And then notice these coagulation markers, which are actually quite important. So depending on the cause of the hemolysis, the fibrinogen may be decreased, and D-dimer is actually frequently increased in hemolytic anemia. And D-dimer, and a lot of times you'll have these patients with hemolytic anemia having high D-dimers, and actually that corresponds to increased thrombotic risk, especially in patients with immune hemolytic anemia. And we feel very reluctant about giving them DVT prophylaxis because their hemoglobins are 6, but also this is the time when they're most prone to thrombosis. So it's actually essential to give DVT prophylaxis to patients with autoimmune hemolytic anemia. So I'm going to do a case, and I hope that I will get some participation with that. So this is a 28-year-old woman who presents with severe fatigue and dyspnea and exertion, and her hemoglobin is 5, and her absolute reticulocyte count is 20,000, which is severely decreased. 2 weeks ago, her son had a cold, and his cheeks looked like they were slapped. She has a history of mild chronic stable anemia. She's been treated with iron in the past without significant improvement. She recalls that her father was anemic as well and had his gallbladder removed in his 20s. And actually 3 months ago, she had a blood count which was fairly with a white cell count of 6.2, with normal differential and hemoglobin of 9.8, platelets of 250, MCV of 81, RDW of 17, and absolute reticulocyte count at that time was 200,000. Her peripheral blood smear is shown below, and what do you think is responsible for the current clinical picture? You can wave. Is it A, folate deficiency? No. Hyperhemolytic crisis? No. Okay, is it a plastic crisis? Yes, okay. Okay, so very good, thank you. So if you look at the smear, you see a bunch of these cells which have no central pallor. And they're look kind of smaller than the rest of the cells, right? So they're called spherocytes. And the spherocytes, the two main conditions in which you see the spherocytes are warm autoimmune hemolytic anemia or hereditary spherocytosis, right? It's the red cell that's missing a part of the membrane and therefore has basically like a balloon-like shape. You don't see any central pallor. And you can also see those cells in a recent blood transfusion and in other hemolytic anemias whenever a piece of the red cell membrane is missing. But as I've mentioned, when you see a predominance of these cells, and there's really a lot of them, your two things are either autoimmune hemolytic anemia or hereditary spherocytosis. And in this patient, it sounds like there's some kind of hemolytic anemia that was going on in the past based on the reticulocytosis with a positive family history. And it looks like the retic count now is low, which is probably related to a plastic crisis caused by parvovirus B19. And it's important to realize that these patients with the reticulocyte count of 200,000, they're really dependent on that retic count to maintain their hemoglobin. So if something brings down the reticulocyte count, like a viral infection, they become anemic very quick because they drop 200,000 red cells a day because they're not producing them. So a few words about the hereditary spherocytosis. It is the most common congenital membrane defect, and it's seen in about 1 in 5,000 people, but in Northern Europe it's more common and seen in about 1 in 2,000 people. And it's an autosomal dominant defect, which involves either ankyrin or spectrin. The problem here lies in coupling of the cytoskeleton to the lipid bilayer. So this portion over here is not coupled properly. So you kind of have the membrane not attached to the cytoskeleton. So the membrane is kind of running on the loose. It's unstable. Pieces of membrane basically detach and you lose some of them. And that's how the spherocytes formed. In addition, when the red cells go through the spleen, macrophages take a bite of the red cell membrane or basically eat the little spherocytes the next time they go through the sphere. An important clinical point is that you have high hemoglobin per cell, right? So your mean corpuscular hemoglobin concentration is fairly high. And the value of over 36 has sensitivity of about 90% for detecting spherocytes, which is generally is a hereditary spherocytosis. So you need excess membrane for deformability because the red cell is about 7 microns in size, and the splenic cords are about 3 to 4 microns in size, and maybe 5. So the red cell should be able to squish through the splenic cords. When you have minimal surface area to volume ratio, the red cell is round, kind of like a balloon, and it's not deformable. And any physical trauma to that will cause it to pop or get consumed by the macrophages. So on the left here, you see the normal osmotic fragility test, which is kind of an antiquated test. It's probably going to be replaced by more sophisticated techniques in the future, where what you do is you expose the red cell solution to progressively more hypotonic concentration of normal saline. And in the hereditary spherocytosis, the red cells will pop earlier. So the solution of saline does not need to be as hypotonic for the red cell to lyse. The more recently, the test for the hereditary spherocytosis is called the EMA binding test, or eosin 5 maleimide binding, which is basically a fluorescent dye that binds to the red cell membrane proteins, and specifically band3 and other Rh-related proteins. And it's decreased in hereditary spherocytosis. This is a flow cytometry-based test, and it's available in Montefiore as a send-out. So for diagnosis of hereditary spherocytosis, if that's what you suspect, the first step would be to do the osmotic fragility. And then the next step would be to order the EMA binding. And there are more sophisticated DNA tests available as well. Clinically, the presentation can be variable, with majority of people having chronic moderate disease that presents in infancy as jaundice and anemia. But some patients can be asymptomatic. There is generally family history of anemia, jaundice, and splenectomy. Patients can present with Coombs negative hemolytic anemia. Again, splenomegaly, gallstones. They can have a hyperhemolytic crisis where something triggers hemolysis and the hemolysis gets exacerbated, and even the transfused, if the patient gets a transfusion, even the transfused cells are involved. They can have a plastic crisis with parvovirus B19, as we've seen in the prior case. And the treatment in the majority of cases is really supportive. Folic acid is the mainstay of treatment because these people rely on increased folate for their increased cell turnover. And in the severe cases, splenectomy is still being used. So I want to move on to the next case. And this is a 26-year-old African-American man who came in initially to urgent care center with a fever, frequent urination, and dysuria. And his CBC revealed a white count of 16,000 with neutrophilic predominance, had a normal hemoglobin and platelet count. He was given nitrofurantoin and came back 2 days later with fatigue and dyspnea and exertion. He denied dysuria, but on further questioning, he did notice dark-colored urine. On examination, he is icteric, pale, tachycardic. There's no hepatosplenomegaly. CBC reveals a white count of 11, hemoglobin of 7, and platelet count of 200. Peripheral smear reveals bite cells and Heinz bodies. What do you guys think is going on? I know you know what's going on. Anybody?
The G6PD.
G6PD deficiency, correct. Thank you so much. So this is a G6PD deficiency. And the clue here, there's a lot of clues here, right? There are all the right buzzwords here. Possibly the ethnicity, the medication that the patient received, the drop in hemoglobin that was possibly related to medication, right? So G6PD deficiency is something you should consider in drug-induced hemolytic anemia, especially if your direct Coombs is negative. So This drug-induced hemolytic anemia in a person of the right ethnic background with negative direct COMS should really bring the consideration of G6PD deficiency. So why does this happen? So you guys know that the red cells has really, it's just pure oxygen carrier, right? There's no nucleus, no mitochondria, no ribosomes. So the red cell can't really generate the energy by itself. And because it doesn't have the mitochondria, it really does not, it's not able to participate in aerobic metabolism. So all the energy that the red cell can generate really comes from anaerobic metabolism, utilizing the pentose phosphate shunt, and that energy and the key enzyme here is G6PD, which basically regenerates your NADPH, which regenerates your glutathione. And this energy is used to maintain the membrane shape, to maintain the cationic balance, to prevent the oxidative damage, to provide the 2,3-DPG, and to maintain hemoglobin in its functional form. When the red cell gets stressed, oxidative the red cell gets stress from some kind of oxidative stress, the hemoglobin gets denatured, and you form these little dots here, which are called the Heinz bodies, which then are removed by reticular endothelial system. And then what you end up seeing on the peripheral smear are the bite cells, which I'll show you in the next picture. And you also get membrane oxidation, which makes membrane less deformable, which results in predominantly extravascular hemolysis, but there is also a component of intravascular hemolysis and hemoglobinuria. So remember, this would be a good case if the ER did not order your haptoglobin LDH, and you're seeing the patient 2 weeks later. That would be an ideal case to send off urine hemosiderin. And why do we have different genotypes? Well, the energy needs of our regular cells decline with the age of the cell. So when we have a normal enzyme under normal circumstances, this enzyme's half-life is 62 days, which basically is enough to last for the lifespan of a normal red cell. And the normal variant is called B, and the gene for G6PD deficiency, as you guys all know, is X-linked, so it's located in the X chromosome. In African American variant, which is referred to as A-, the half-life of the enzyme is only 13 days, which means that it really does not last enough for the lifespan of the red cells. But it's barely, usually, enough for them to get by. It does last through half the lifespan of the red cells. So the hemolysis that happens is usually hemolysis with severe oxidative stress, which usually is either a medication or an infection. In Mediterranean variant, which is a B- variant, the half-life is a few hours. So even the smallest oxidative stress depletes your glutathiones, and the red cell is not able to deal with it. So you get hemolysis with even mild oxidative stress. And the classic example, of course, is the fava beans. The carriers of all these genotypes are protected against malaria, which is why we have this mutation to begin with, right? It's providing selective advantage. The precipitating factors, as I've mentioned, could be any type of infection, could be fava beans, could be naphthalene or mothballs, which I don't believe we use anymore. But things like henna for cosmetic use in Asia, and medications. And from the medications, the big offenders are primaquine, sulfonamides such as dapsone, quinolones, methylene blue, nitrofurantoin, and nalidixic acid. And there is a list of medications that you should be testing for G6PD deficiency prior to initiating the patient on it, especially if they're of the appropriate clinical background. And on this smear, you see the blister cell, as I've mentioned, and you see the bite cells over here. You guys are able to see me pointing, right? Yes? Okay, next case. So this is a 55-year-old man who goes to his doctor for regular checkups and was seen most recently 6 months earlier. He's never been sick and never had a surgery. And now he's presenting with fatigue, pallor, and a hemoglobin of 8. He has an MCV of 92 and a reticulocyte count of 10%, corresponding to absolute reticulocyte count of 250,000. His direct Coombs is positive for IgG. His indirect Coombs is positive. His LOH shows a panagglutinin. Initial treatment of this patient should include, are we talking about steroids, plasmapheresis, immediate splenectomy, or chemotherapy? Anybody? Cold hematology, right? So the correct answer, the answer I would have picked would be the steroids, right? So he has what seems to be a new anemia. It does not sound from the history that there was any antecedent drugs or infections. And he has a positive direct Coombs, and we'll go a little bit into details. What are these things like direct Coombs, indirect Coombs, and LOA? So it's probably warm autoimmune hemolytic anemia. The initial treatment for that is steroids. So let's talk about the warm autoimmune hemolytic anemia. And I'm going to speed up a little bit because we're a little bit behind. So autoimmune hemolytic anemia, about 60 to 70% of that is represented by warm autoimmune hemolytic anemia, and about a quarter is what's called the cold agglutinin disease. And then there are some mixed cases. Was there a question? Okay. Autoimmune hemolytic anemia is defined by antibody-mediated destruction of red cells with or without complement involvement. And it's diagnosed by presence of the antibodies or complement on the surface of red cells by direct Coombs. You can see it in any age, but the risk does increase with age. It's much more common in adults, though, although childhood cases do exist. And the risk increases after the age of 40. What determines whether the anemia is warm, cold, or whether the patient is even going to hemolyze? It's what's called the thermal amplitude of the antibody. So if the antibodies act at the body temperature, so 37 degrees Celsius, then it's defined as warm autoimmune hemolytic anemia. If the antibodies act below the body temperature, it's called cold autoimmune hemolytic anemia. And the closer to the body temperature that the thermal amplitude is in the cold autoimmune hemolytic anemia, the more severe it is. So this is the classification. So in warm autoimmune hemolytic anemia, the pathogenic antibody is generally IgG, but can occasionally be IgA. And the temperature at which the agglutination happens is 37 degrees. If you do a direct Coombs, which is a test that looks for presence of antibody on the surface of red cells, it will be positive for IgG. About half of the cases are idiopathic, meaning that we really didn't find any underlying condition, although there could be disease associations such as other autoimmune disorders. And then in about, I don't know, 20% of cases, it's secondary to lymphoproliferative disorders such as CLL or Hodgkin's disease or other non-Hodgkin's lymphomas, lupus and other autoimmune diseases such as sarcoid can also be associated with warm autoimmune hemolytic anemia. And as I've promised before, there's a drug-induced hemolytic anemia category. All of these cases, you get a positive direct Coombs. The type is actually important and frequently tested on standardized testing. And actually is related to treatment, so it is important. So the type 1 is a hapten mediated. Hapten is a small protein that by itself is too small to be antigenic. But when it's combined or presented in association with another protein, then it becomes antigenic. So penicillin by itself is too small to cause trouble, but when the immune system recognizes it on the surface of the red cell, then you can have a formation of antibodies against penicillin and red cell antigen system. Why is this important? Well, if you see the patient started on penicillin and started hemolyzing with a positive direct Coombs, all you need to do is stop the penicillin, right? It's not an immune process against just the red cells. Once the penicillin is out of the system, which usually takes a couple of days, the hemolysis should subside. So steroids are not necessary in this case. Similarly, the type 2 drug-induced hemolytic anemia is immune complex mediated disease. So so this is basically a hematologic version of serum sickness. And the drugs that commonly cause it are quinine as well as cephalosporins. And again, once the drug is out of the system, hemolysis subsides and no steroids are necessary. So in this case, basically, the antibody is directed against the drug itself, and then the antibody drug complex binds to the surface of red cells and targets it for destruction. The type 3 autoimmune hemolytic anemia is the true antibody against the red cells. So certain drugs such as methyl-dopa, and this is why it's no longer used outside of pregnancy, and I'm not even sure if they still even use it in pregnancy, alters the red cells antigens and makes them very antigenic. And after that, even once you stop the methyl-dopa, you still get a garden variety autoimmune hemolytic anemia related to that, and which requires therapy just like a regular autoimmune hemolytic anemia. And with methyl-dopa, the frequency was actually about 10%, which is why they took it off the general use. On the peripheral blood smear with warm autoimmune hemolytic anemia, you see spherocytes, as we've discussed, which is basically, and I'll go into pathophysiology a little bit later, but the antibody binding to a red cell antigen, and then the macrophage takes a bite. And again, the red cell is missing part of the membrane. The management, a general rule, if there is a secondary cause for warm autoimmune hemolytic anemia, for example, lupus, you try to address it. The steroids we use in the first line, prednisone, 1 milligram per kilogram per day. There are other immunosuppressants that are used. The second line therapy is rituximab, and potentially, eventually, will become a first line therapy as well. Cold autoimmune hemolytic anemia is generally caused by IgM antibodies with a glutination temperature that of below core body temperature, so between 4 and 37 degrees. The direct Coombs generally is positive for complement, and again, we have idiopathic form, or cold agglutinin disease is the other name for it. We have a form that's secondary to infection, with mycoplasma and EBV being the most common causes, and lymphoproliferative disorders such as Waldenstrom's macroglobulinemia and CLL. On the peripheral blood smear, you generally see agglutination. Therapy involves warming up the patient, trying to address the underlying cause. So again, if it's lupus, control the lupus. If it's pneumonia, treat the pneumonia. And then rituximab and immunosuppression. And plasmapheresis is used in emergency cases. And I'll go into that a little bit more into detail. So I think in the interest of time, I will skip this slide. This basically describes the method of the direct Coombs. And as I've mentioned, this is a test to determine whether there are antibodies present on the surface of red cells. So you take the red cells, you wash them, you add anti-human globulin reagent, which cross-links the antibody-coated red cells, and you see agglutination, which really looks like this, like little clumps. You start testing with polyspecific Coombs, which means that this Coombs has anti-IgG and anti-C3. So anti-C3d is the complement component of it. Then once it's positive in our lab, generally we have anti-IgG testing. And if IgG is positive, we presume that this is a warm autoimmune hemolytic anemia. So what's eluate? So when the direct Coombs is positive, we want to know what this antibody is directed against. So we know the antibody is on the surface of the red cells, but what is it against? We don't know. It's kind of like an SPEP. So we know there is a monoclonal protein, but we don't know what it's called. So we do an immunofixation electrophoresis. So this is the elution. And basically what's done is you take the antibody-coated red cells, you need to process them very gently that in order to remove the antibody so you can test it, but yet you don't want to destroy the antibody. So they usually either heat or freeze thaw it, and which is used for hemolytic disease of the newborn, or use acid or organic solvent, which is used in warm autoimmune hemolytic anemia. And then they tested against the panel of cells with known antigens to determine the antibody specificity. And usually in warm autoimmune hemolytic anemia, you'll get an answer the direct Coombs is positive, the antibody is panagglutinin. And the reason it's panagglutinin is because it reacts against all the cells. It's directed against an antigen that all of us have. It's not specific to any specific red cell antigen. Well, it is, but it's a common antigen. So what's the pathophysiology of red cell destruction in warm autoimmune hemolytic anemia? Well, it actually goes way beyond just a simple phagocytosis of antibody-coated red cells. It starts with, so it involves several different mechanisms. So the antibody-coated red cells are either taken up by Fc gamma portion of the macrophage. Macrophages have receptors for the Fc gamma portion, and either they're taken up by them, and they either get phagocytized or they become little spherocytes, as you can see in the part B, or this antibody-coated red cell binds to Fc gamma portion of the T cell or a natural killer cells, and you engage what's called antibody-dependent cytotoxicity. And then if that wasn't enough, the antibody-coated red cell can engage complement. And if the complement cascade completes, then you can have a small element of intravascular hemolysis in the system. And if it doesn't complete, then you get a C3b deposited on the surface of red cells. And actually your liver has receptors for C3b, so these red cells can also be eaten up in the liver. So that's that. In terms of the treatment I've mentioned, you try to focus on treating underlying disease, such as malignancy. If there's autoimmune hemolytic anemia in the setting of CLL or lymphoma, you try to address that. You stop the offending medication. The steroids, we usually use prednisone at 1 milligram per kilogram per day. However, in severe cases, higher doses could be used, including salumedrol at 1.6 milligrams per kilogram per day. Rituximab, which is a monoclonal antibody against CD20, which is an antigen on B cells, has well-established role in the second line and is currently the recommended therapy in the second line. And actually has data in first line as well. So this slide, this graph here is from an article where they used rituximab in the first line setting in addition to prednisone. And what they were able to show is that progression-free survival or relapse-free survival was actually significantly reduced in patients who received first-line rituximab therapy as opposed to patients who received steroids alone. Third-line therapies vary. Splenectomy historically has been second-line treatment of choice until it was replaced by Rituxan. And now it's probably third-line agent. It's 70 to 80% effective initially. However, if you look at these patients about 5 years later, only about 20% remain in a long-term remission. So this is really an area of active investigation. What do we do with people who relapse on Rituxan? Do we give them more Rituxan? Do we give them something else? We still remove the spleens, but like I said, you know, eventually it's not in the long run, it's not the most effective therapy. And then there's a whole bunch of other therapies such as cyclosporin and azathioprine, which are the two probably preferred agents in the third line plus setting, and a cyclophosphamide. IVIG doesn't work well in contrast to ITP. A good place for IVIG is really, so response rate for IVIG is about 40%. And the best efficacy and the best results were seen in patients with severe hemolytic anemia, hemoglobins 4 to 6. And in that case, you really use high doses of IVIG, about 3 to 5 grams per kilogram total dose. So if you're using 1 gram per kilogram per day, you have to do it for 3 to 5 days. And then there's a bunch of new agents that are currently being investigated, and some of them are going to be approved fairly soon for this condition. And they include Syk inhibitors, which inhibit phagocytosis as well as B cell function. Syk is an enzyme that's intimately involved in B cell receptor signaling as well as phagocytosis. There are B cell receptor pathway inhibitors such as PI3K kinase inhibitors. In patients in whom complement-mediated hemolysis plays a big role, which is not everybody, C3 blockade is being investigated. Proteasome inhibitors, so drugs that inhibit plasma cell function, because plasma cells are what's making the red cell, making the antibodies, are being looked at as well. A very interesting pathophysiology is utilized by this FcRn inhibitors, and this is actually fairly interesting. I'm not sure how useful it's going to be in the future, because most of these drugs are intravenous, but about 75% of immunoglobulins that are circulating, IgG that are circulating, are not really produced, but they're recycled. So what these drugs, and they're recycled through the FcRn receptor, which is a neonatal receptor that allows for transplacental passage of the maternal immunoglobulins to the fetus. But it also is involved in recycling of IgG in adults. So when you block this pathway, you basically block recycling of your 75% of your immunoglobulins. Your immunoglobulins drop. Most of the autoimmune diseases are immunoglobulin mediated. So immunoglobulin mediated diseases do better. But you also get hypogammaglobulinemia. And those drugs right now are intravenous. Anyway, they're being studied in autoimmune hemolytic anemia and lots of other antibody-mediated diseases. And the new kid on the block, borrowing from CLL, is the Bruton tyrosine kinase inhibitors, which are just beginning to show some data. And I'm not gonna go much more into that. Okay, last case, and we'll finish it and probably stop there. So this is a 56-year-old woman who presents with pain in her fingers and toes. She noticed that they're purple. Her symptoms improve when she's indoors. On a physical exam, there's bluish discoloration of ears, nose tip and fingers. There's hepatomegaly. Her red cell count is 1.52 million. Her hemoglobin is 9.7. Hematocrit is 13. So notice the dissociation here between the red cells, the hemoglobin, and the hematocrit. Those numbers look a little crazy. The MCV is 145, and the reticulocyte count is 7%. So which of the following is associated with that? So this, you probably guessed, is a cold agglutinin disease, cold autoimmune hemolytic anemia, which is usually caused by IgM. So IgM usually fixes complement in cold exposed areas. And then once the red cell moves centrally, it dissociates from the surface of the red cell, and it leaves complement on the surface. So the correct answer here is B. Direct Coombs is positive for complement only. So cold autoimmune hemolytic anemia is characterized by an IgM, which is directed against the carbohydrate antigens on the red cell surface, such as I antigen. Really three main subtypes. The primary or idiopathic is called cold agglutinin disease. And it's actually now been shown to be a distinct but hematopathologic entity, which is actually similar to a low-grade lymphoma, which is distinct from the regular lymphoma that can cause cold agglutinin syndrome. And then there's transient cold autoimmune hemolytic anemia that can be caused by infections, most commonly mycoplasma or infectious mononucleosis. The big I and the small I are important here, and as you can see in the primary cold idiopathic cold agglutinin disease, is usually caused by big I. The small i's can be caused by infectious mononucleosis or a lymphoma. So the general teaching is that if your cold agglutinin specificity is a small I, and the patient does not have infectious mononucleosis, then you really should be looking for a lymphoma, because that's your next thing on the differential. So if the patient comes in with cold autoimmune hemolytic anemia, you want to rule out infections such as mycoplasma and mono, and then you want to rule out lymphoma specifically if it's anti-small I. Disease is characterized by anemia and intermittent hemoglobinuria and acrocyanosis on cold exposure, which is a Raynaud syndrome. On a smear, you see red cell clumping and agglutination. You see crazy MCV that's unbelievable and unreliable. You also see elevated MCHC. Your direct Coombs is positive for complement only, and your elevate is negative because remember, there's no antibody on the surface of red cells. In general, to be clinically significant, the cold agglutinin titer needs to be greater than 1 to 64, although there are exceptions to this rule. But you will see positive cold agglutinin titer, but then, it says less than 1 to 20, which means, yes, there is a cold agglutinin present, but it's not clinically significant. This is what it looks like in extreme cases when you can actually have gangrene of the digits and nose and ears with this disease. And this is what it looks like on the peripheral blood smear with agglutination of the red cells. The pathophysiology is basically you have the IgM binding to the surface of red cells, as I've mentioned, on a cold. It fixes the C1 complement, which recruits the complement cascade, including complement factor 4, complement factor 2, and C3. That leads, and those are all part of the classical complement pathway. That leads to eventually to formation of C3b on the surface of red cells, which is where all these complement pathways are converged. And then if you remember from the warm autoimmune hemolytic anemia, I mentioned that the liver has the C3b receptors. So these C3b coded antibodies are taken up by the liver, gets phagocytized, and you have predominantly extravascular hemolysis. If the complement cascade completes and you have the formation of the membrane attack complex, you can potentially get the intravascular hemolysis as well. But normally on the surface of red cells, we have this enzyme called CD55, which is missing, by the way, in PNH, right? So that generally protects the cells from complement-mediated hemolysis in the circulation, unless you really have a lot of complement and you overwhelm this ability, or unless you have PNH. In terms of treatment, as I've mentioned, we want to avoid cold exposure. We want to treat underlying disease if there is any. Steroids and splenectomy don't help. If you remember, the destruction of red cells take place in the liver, so you can't really, taking out the spleen is not going to be helpful. Steroids are really not helpful as well. Rituximab is the first-line therapy. It's associated with response rates of about 50% as a single agent, but really not much of complete response rates, and it doesn't last that long. Using alkylating agents such as bendamustine with Rituxan, which is chemotherapy we use for lymphoma, which is where the idea came from. Once we recognized that cold agglutinin disease is a lymphoma, is actually much more effective and is the preferred therapy in people whose overall shape allows this administration. And it results in response rate of about 70 to 80%, which lasts for years. And there is a good proportion of complete responses there as well. In acute cases, we do plasmapheresis. And then there's a whole bunch of novel therapies that are coming up. Most importantly, and the one that's probably going to be approved really soon, is a C1 inhibitor, so the inhibitor of the first part of the complement cascade, which actually has very good efficacy in this disease. But PIK3 kinase inhibitors and proteasome inhibitors play a role as well, and actually proteasome inhibitors are being used in these conditions as well. And the new thing that's up and coming are BTK inhibitors. And I think with that, I'm going to stop. If anybody has any questions, I'm happy to answer. You're welcome to